Hello, my name is Izuchukwu Azuko Kafo. It's nice to meet you all, I think, for the first time. Um, it's unfortunate that we have to be on a very long, unnecessary holiday, the strike, I mean. But we are back now, and I think we are ready to hit the ground running. So I welcome you all back to this semester. And I hope that you also become very serious and hit the ground running as well. No more excuses. Pick up your books, pick up your bags. If you're still in your house, I think it's time for you to start coming back. Lectures have resumed, and exams are coming very soon by December. I'm sure you've all seen the course outline, and you've also known your lecturers, and I hope that you begin immediately. So just to ensure that we have a very strong internet connection while I'm on this lecture, I'm going to put off my video for a while. At least this is just for you to see my face. Hopefully, when we get to see physically, you at least get to know who thought exactly what. Okay, so I'm hopeful to see you guys physically very soon. And for now, I'm going to be teaching on the osteology of the clavicle, scapula, and humerus. So I will put up my video and then share my screen. Okay, so basically, when you talk about osteology, there are key things that you need to know, key things that you need to look out for. Any bone at all that you want to review in anatomy, you want to talk about what is the basic definition of this bone, where is it found, what is the role of this bone in the body, and then most importantly, you want to know, what does this bone support in terms of muscular attachments or any other clinical implication that is related to that particular bony structure. So clavicle, scapula, and humerus are three bones that are strategic in the upper limb. So if you don't know anything at all, these are the three key bones that you must get to know. Whatever it is you study, I'm sure I'm talking to the health science students. So irrespective of your department, radiography, physiotherapy, at one point or the other, you're going to be doing more advanced, clinical application of the knowledge you're going to get from this. And of course, your exams, your quizzes, yeah, you are going to be getting some basic questions that show that you have truly understood what these bones are. What are the muscular attachments? At what point, at what origin, what are the features that you can see that will make you to appreciate the level of knowledge you have concerning them. So we want to start with the clavicle. First of all, I want to charge all of you to think of borrowing a bone. You might want to borrow clavicle, you might want to borrow humerus, or you might want to also borrow the scapula as well. When you borrow it, you appreciate how it looks, you turn it all around, you'll be able to, understand it better because you're having a 3D, view of it. So you can view it from every angle and begin to see how it really looks. So this is the clavicle, as you can see. I'm still going to be telling us how you are going to know whether it's from the right or from the left. By the time we begin to define what exactly it is and what are the features, then the features will be able to tell you how to position it to be able to know whether what you're having, is actually the left, the right, or otherwise about that particular bone. So clavicle is a long bone, horizontally placed in the upper limb. It is a connector. I like to call it a connector, between the axial and appendicular skeleton. So it is one of the major key bones that actually forms what we describe as the pectoral girdle, or what you normally call colloquially as the shoulder girdle. So it is horizontally placed long bone. It has two ends, it has two surfaces, and it has about 3 divisions. So we're going to be looking at some of the surfaces on the end. So we have the medial end and the lateral end. So you can see the medial end is actually a rounded, it's round in nature, while the lateral end is actually flattened out in nature. So you can appreciate the convexity, across the lateral end, and you can appreciate the concavity across the medial end. So you can see that it is actually a sigmoid. Some call it a sigmoid or S-shaped bone because of this particular shape. So now you have 2 surfaces, the anterior surface and the posterior surface. So I think by now you should be able to get acquainted with the terminology, the nomenclature we use in anatomy: anterior, posterior, medial, lateral, and so on. So these are common words you'll be hearing more often. I understand that this is your first semester and tutorial level, so you might just want to take your time to begin to understand it, make an image memory, when you hear them. So when we say it is medial, it means that it is very close to the midline of the body. So midline is like, for example, when you touch the bridge between your 2 eyes, down your nose, down your mouth, in between the middle of your mouth, down, to your neck, down to your mandible, the sternum. That's what you call the breastbone. Down and down to your pelvis, to your perineum, as if you're trying to divide yourself from the head into 2 halves. That is the midline. So when something, any particular structure is very close to that midline, we say it is medial. But when it is going away from the midline, we say that that particular structure is lateral. So that is a simple, uncomplicated explanation of what it looks like. So medial, from here, from this definition now, you can see that we can easily tell where this bone is coming from. Can we tell? So we can tell. So if we say that this is the medial end and this is the way it looks, the medial end has a concavity that now, flattens out with a convexity. So at the lateral part. So that tells us that the bone we are dealing with is the left clavicle. Take a look at it again. From the medial end to the lateral end, you can see the anterior and the posterior. So when you are given a bone, for those of you that have to face clinical exam, I don't think much of you do that. Maybe for those in medicine and anatomy that we normally examine physically. So you might want to, we can ask you, pick a bone, and then we'll begin to ask you to first of all identify whether it's the left or the right bone that you have. So the medial end of the clavicle actually articulates with the mandible of the sternum and forms what we call the sternoclavicular joint. You can see that particular arrow there. Let me get my laser pointer. So you can see at the point at which the medial end is making a connection with the mandible of the sternum. So this is the mandible of the sternum, what you call colloquially the breastbone. Please don't, when I say colloquially, it means that it is not accepted, it's not the right nomenclature. So you write what is anatomically accepted. So get used to using anatomical terms than using colloquial language. But I'm trying to relate with you because you are new, to the medical terminology, so that with time you get used to it. So the medial end articulates with the mandible of the sternum to form what we call the sternoclavicular joint. That is one thing that you need to know about the language of anatomy. We use connectors. So you don't need to cram anything about names. You don't really need to. You need to connect to why those names are given. For example, sternoclavicular joint, the sternum, a connection between the sternum and the clavicle. So that is why it is called sternoclavicular. Very simple. So when you hear sternoclavicle, something tells you from the sternum to the clavicle. So it is a joint between the medial end of the clavicle and the mandible of the sternum. So the lateral end of the clavicle articulates with the acromion of the scapula. We're still going to see what the acromion end of the scapula looks like, and they form what we call the acromioclavicular joint. Again, the name makes the sound and gets you the meaning very easily. Okay, and the clavicle is divided into thirds. The first third, the second third, or what we call the middle shaft, and then you can see the first, the flattened part, the middle, and then we have the third, the third part of it. So it is divided into thirds along its length. So we have the lateral third, what we call the flattened part of it, with several impressions. We're going to be seeing the specific impressions you can see. So assuming we have a physical bone here, you're going to appreciate some of these depressions you're seeing and some of these protrusions you're seeing on the bone and what they actually mean. You can see that at the medial end. So it has the lateral end, we have the medial third, and then we can say the medial, we can also call this the medial 1/3, the lateral 1/3, okay, the middle 1/3. We normally describe it as such. So you can say we have the lateral 1/3, the medial 1/3, and the middle 1/3. So the medial third is actually rounded, as I've said before. And then, of course, you now have the seemingly rounded middle part as well. So the clavicle is curved convex forwards at its medial end. So you can see the convexity along that line, okay? So you can see the convexity along from the medial end and then flattens out into a concave, at the lateral end. So you can see how it begins to curve to form the X shape or the sigmoid shape at the interior part. So, and then you see the concavity, sorry, I keep interchanging that, the concavity at the lateral end of it. Okay, there are a number of impressions on the surface. You see, first of all, let's look at one of the two coracoclavicular ligaments. From the word coracoclavicular, it means that there is a connection between the coracoid process of the scapula and the clavicle. So it's a connection between two things, two structures. So these two ligaments are actually what makes up the coracoclavicular ligaments. One of them is the trapezoid ligament, and the other one is the conoid ligament. So there is what we call a trapezoid groove. You can see that. So this area, what we call the trapezoid groove, is where you have the trapezoid ligament being impressed. This mark you're seeing right here at the lateral end. Okay. Then the other part of this ligament, coracoclavicular ligament, is called the conoid ligament. Okay. So when you want to describe coracoclavicular ligament, these are the makeup of it. So you can see, assuming, let me go back to the last one, you can see, so both of them actually forms a single ligament we call the coracoclavicular ligament. They are much like aligned together. You have the conoid part of that ligament, and then you have the trapezoid part of that ligament. Okay, that is clear enough. Now, this area on the medial part gives attachment to the costoclavicular ligament that arises from the first costal cartilage and the first rib. Okay, this part on the medial part is the costoclavicular ligament groove. So you're going to see a groove on the medial end of the clavicle that attaches, has the attachment of the costoclavicular ligament. So because there is a relationship with the first costal cartilage, it is called costoclavicular ligament. Take note of that. Take note of that. So this is responsible for strengthening the relationship it has with the sternum. So remember, at the sternum, you're going to have your mandible, you're going to have the ribs, the first rib comes almost immediately after the mandible. So that relationship, this particular costacoclavicular ligament is gets a tie, a strong tie from the first rib, tied it up to the ligament to be able to stabilize that particular joint called the sternoclavicular joint. Now we're going to look at some of the muscles that find the attachment to the clavicle. One of them is deltoid muscle, so you can see the impression. Okay, you can see the deltoid space aligned. Try to align it with the rectum here to indicate. So as you're seeing, you try to make an imagery of what it looks like. You know, the attachment of these muscles. You already know where your deltoid muscle is. Okay, so when you think of deltoid, you're going to think, when we talk about attachment, generally we talk about both proximal and distal attachment. Proximal attachment means the origin where that muscle is coming from. And then distal attachment means the insertion where that muscle is going to. So if you have a stretch of muscle, for example, from the clavicle and is going to the humerus, for example, it's going to be a stretch from the clavicle down to the humerus, which is on the arm. So now you're going to see that the proximal attachment is the part that is very close, to the beginning or the origin actually. And then distal is at the point at which it makes its final insertion, the final settlement of that particular muscle. So this muscle finds attachment at this place and takes its origin from the lateral end at the anterior surface of the lateral end of the clavicle. We have the P major muscle, or we call the pectoralis major. It's also allowed to call it P major when you put P with a dot, then it's a major. So we also have the P minor, the pectoralis minor as well. So, but P major takes its origin on the anterior surface of the medial end. From the middle part, stretches from the middle part down to the lateral medial third at the anterior surface of the clavicle. We have the subclavius. Subclavius actually takes the word sub. It means that it finds itself, lying just below it, just below the clavicle. So you can see its insertion at this point, almost coming towards the posterior part of the clavicle. Now we have a very small muscle called the trapezius that lies at the trapezoid. Remember, trapezoid, we talked about the trapezoid ligament and we talked about the conal ligament. Do you remember that? So we talked about these two ligaments that are called the coracoclavicular ligaments. So these two ligaments, you can see the relationship. Now we're talking about the trapezius muscle. I remember that initially that ligament I mentioned is found here, the trapezoid, and then the conoid is found here. Okay, now you can see the relationship between the ligament and this muscle called trapezius. So that gives you a picture of the fact that these things have relationship, and anatomy is all about relationship. It's all about what are the close structures, how do you relate to them. So when you make a picture image and you make a memory that helps you to remember, and you don't need to cram anything at all. So trapezius is a muscle, but trapezoid is a ligament. Take note of that. So at the lateral tip, at the tapering lateral end of the clavicle, you're going to see the trapezius, finding its origin at that point. So finally, we're going to be having the stenohyoid muscle, stretches from the small hyoid bone, towards the neck, and then the sternum of the mandible. Okay, so you can see, so it finds its attachment here. This is actually the stellar attachment at the medial part of the clavicle as well. So this is just to show you a summary of the muscles that attach to the clavicle, and for you to have a picture memory. You can actually create a mnemonics around it. We normally create mnemonics, something you can use to remember. And if we want to ask you some questions, we will pick some of these features, attachment, muscles, and so on, to be able to, test your understanding of some of these basic things. So what meaning do we make out of clavicle? Why do we want to know about clavicle? How does it relate to you? Clavicle fractures is very important to note as a clinical correlate of clavicle. Okay. Another thing you need to know, something particular about the fracture is that it happens more in the medial 2/3 or the lateral 1/3. So from that point is actually one of the weak, assuming you can make it feel, you can touch it, you will discover that at that point, at the lateral 1/3, assuming we divide, remember the division I showed you where you have the thirds, the first part, the second, the middle, and the third part. So when we say the medial 2/3, it means from the middle to the second part. So that means the lateral 1/3. So that is the weakest point of the clavicle. And most times when you have a trauma and we have a pressure or fall of anybody, children or old persons, normally fracture tends to happen more in those areas. So we call it the mid shaft. It's also part of the mid shaft, and then towards also the medial 2/3. So I've earlier mentioned that it is the connector of the exoskeleton to the pectoral girdle. And then it's also the first bone in the human skeleton to ossify. Very important. These are things you need to know. So the implication of the ossification is that we use this to be able to do bone dating. We use that to be able to know aging, and we'll be able to use that information also when we are making maybe radiographs or MRI and so on and so forth. That helps us to be able to call it, diagnose issues, and make clinical decisions as well. Now let's look at the scapula. Now this is just to show you how it looks like, how it pops up. Of course, so you can appreciate it. For those in physiotherapy, when you look, you actually will be able to know movements, kinesis, know how the body is structured. When you look at someone, you'll be able to easily detect it without making a touch. When particular bone is not well placed, or when particular movement is being impeded. So this is to show you that when you stand akimbo or with the hands on your waist, you can easily have the scapula on both sides being, protruding from the back. So you can appreciate it, from the back, from your back, rather than from the front. So the scapula is very mobile and is situated on the posterior aspect of the body. Is actually best viewed from behind, and we have two of them, of course, on either side of the spinal column, more like as if it's a pad, a pad on the body, a pad on the rib cage, and overlying, over two from the second to the seventh. That's actually the length of the breadth from the superior part down to the tapering lateral end. Okay, so I've said all this already, that is best viewed from behind and lies between the second and the seventh rib. So it's a flat triangular shaped bone, has two surfaces, he has three borders, he has three angles, he has three projections. These are things that you need to know. So this is the anterior view. As we're going to go from the front, this is what we see. So if we're going from the frontal part of the body, this is exactly what you see. So you can see the triangular nature of this bone. How does it look? Very nice, but you can see like those projections that come, on it. So all these parts are just to show you, make you appreciate it a little bit more. So now you can see the anterior part, you can see the posterior part, you can also see the lateral view. So I'm trying to show you the lateral view. This point is the point at which it makes its attachment to the glenoid of the humerus. So it connects, you're able to form the shoulder joint, your shoulder joint. So this is that point where the head of the humerus gets to attach to be able to form the shoulder joint. So two surfaces, we talk about the anterior and the posterior surface. The first one I showed you, this is the anterior, this is the posterior. So within the posterior surface, you have what we call the spinous process, or the spine of the scapula. You can see it winged out, dividing even the posterior part into two different parts. We're going to see that. So we either say anterior or ventral surface, or we call posterior or dorsal surface. So those are the two surfaces. And then we have the posterior part, you have the spine of the scapula being divided into two regions dividing the scapula into two regions and form what we call the infraspinatus fossa, the one that is up the superior part. So this is the superior division. This is the inferior division. So this is what we call the infraspinatus fossa, or infraspinous fossa rather. The infraspinous fossa is a fossa that actually takes on the infraspinatus muscle. So we're going to see that later. So infraspinous fossa takes in that particular muscle. The whole of this area is being latched by that muscle. And then we have the superior part that takes on the supraspinatus. So the supraspinous fossa and the infraspinous fossa. These are the two fossa that is being created by spine at the posterior part of the scapula. So this fossa is more clearly viewed from above, so you can actually see the superior part. Now, this is more like trying to view. This is the bird's eye view. So this is the bird's eye view, trying to view from the top. Okay, so you're going to see the more like the space that takes on the supraspinatus. Now we look at the borders. What are the borders? So we have the medial border, we have the lateral border. So remember medial, we talk about medial, the same thing. You should be able to know which one is the right, which one is the left, the way you look at it, which one is the right or the left. So when you place the medial the way it should be, remember, know the posterior part, the spine, sells it off, that the spine means you are already placing it posterior. So then the lateral part, the medial part, these are the medial parts, on the anterior surface, this is the medial part on the posterior surface. Okay, so this is medial border of the scapula, and then we have the lateral borders, and then we also have the superior border. These are the three borders: superior border, the medial border, and the lateral border. Take note of those. Very important in description of content or structures, relationship, and every other attachment that is being made to it. Now we also have the angles. We have the superior angle, just like we have the superior border. We also have the superior angle. We have the inferior angle. You can see that tipping point. So I'm showing you on both sides, on both views, the anterior surface and the posterior surface, so that you can appreciate it. So the inferior angle, the superior angle I've earlier shown, and of course we also have the lateral angle, basically, which is the facet for the attachment of the glenoid surface of the humerus. Okay, we look at the three angles. The lateral, you can see the anterior, the posterior. You can see the angles. Okay, the anterior, the posterior, and the lateral. Now we look at the projections. The three projections as well. We have the coracoid process, we have the spine process, or the spine of the scapula, and we have the acromion. So these are projections that we can find, that we use them. We've talked about, for example, the coracoclavicular ligament, the acromioclavicular ligament, and we have also talked about the sternoclavicular joint. So these are some of the nomenclatures that are tied to particular structures or projections in some of these bones. So these three, I'm going to be showing us, this is the coracoid process. So you can see it. the coracoid process. Okay, you can see it at the anterior view here. You can also see it the posterior view. Then we look more on it to appreciate it better from the superior view, the way it looks. So you can see the supraspinous fossa. You can see, appreciate it. Okay, that's the coracoid. And then we appreciate the acromion now. So we can appreciate the acromion. Acromion is just the tipping end of the spine. That is why I showed this. And then you can see the tipping end of the spine. So this is when you look at the lateral view, you're going to see that a tipping end of the spine. Okay. So then we now finally see the acromion as well. Okay, see, this is the superior view. Appreciate it better. Let me show it once again. The lateral view, the posterior view, and the superior view. Okay, now let's look at the muscular attachment. The muscular attachment. Let's start with the supraspinatus. I think I've been mentioning them. It sits at the supraspinous fossa, so you can see the attachment at the upper part. Okay, so it attaches to the upper part. So look at the muscle here. Look at the supraspinatus. Look at the way it spines here to attach itself at the greater tuberosity. We're going to see what is called the greater tuberosity of the humerus when we study just a few minutes. We're going to see that the greater tuberosity of the humerus. So you can see it mixing itself, finding its root in between the coracoid and the acromion to be able to find its insertion at that greater tuberosity. And it helps with abduction of the arm. Things you need to know. I'm sure someone else is going to teach you that the ABD, there is difference between abduction and adduction. So it's not the focus of this lecture, but you need to know what a particular muscle is doing, as you learn them as well. So it's abductive. So we're focusing on the osteology. So you get to marry these things across as you study them. Then the infraspinatus, just like the supraspinatus, that finds itself here. So you're going to see the infraspinatus taking a whole lot of space, is bigger than supraspinatus, latching itself at the infraspinal space. Okay, so it attaches itself again at the greater tuberosity of the humerus, and of course helps for rotation, external rotation of the arm. So you can see the way it seems as if it's a long tie. Can you see as if it's a wrap? So you can imagine when this muscle is contracting, if it contracts right now, you're going to see that it's going to cause this bone now to tilt maybe towards the right or the left. So that way it can cause rotation of the arm. So we have the teres minor, which arises from the upper part of the lateral body of the scapula. This is the teres minor. Look at the attachment of the teres minor, and also helps with external rotation. So you can see the way, assuming this is a string, if I draw this string, imagine that this is a string. When I draw this string, it's going to actually tilt that arm to either left or right. So it helps with external rotation. You can see. So that insertion, proximal and distal attachment, will show you the function, will show you what it does. So if you can remember one, you can remember others. Okay, so it attaches again to the greater tuberosity of the proximal humerus. Now, we've talked about how many muscles right now? How many muscles? I think about 3. Let me go back again. The supraspinatus, the infraspinatus, and the what? Supraspinatus, infraspinatus, and teres minor. All of them find their attachment at the greater tuberosity of the humerus, the proximal part of the humerus. Now we have the subscapularis. Subscapularis arises from the whole of the ventral surface. So you can see the subscapular, just beneath the scapula. So the whole of the anterior space. Remember, this is more like the front of the scapula. So this is like the front of the scapula. So it has the subscapular, taking the whole of that muscle. The subscapular fossa. This is actually subscapular fossa. Okay, so it takes the whole of the subscapularis, which is the muscle, and the whole of that surface. Okay, so this is the way it is lashed out. So you can see it here clearly, and the muscle, and it still makes its attachment this time around, not in the greater tuberosity, but in the lesser tuberosity. The word greater and lesser are actually based on the size. Okay, greater and lesser. So the other one is there is more protruded. There is the tubercle is bigger in size. That is also greater and lesser. Okay, so and this time around now, remember the other ones will cause external rotation, as rotating away from the body. But this one is internal rotation, rotating towards the body. So assuming we take this as a string and we draw it, you can see how the body is going to move towards the body. So that is internal rotation. So that's the function of the muscle. So serratus anterior is also another muscle that attaches itself to the medial border anterior aspect, lying down the whole of the medial border. I think we lost a bit of connection, so we're going to go back. Let's see. One minute. Okay, so we're back. I think we are down to, I was talking about the serratus anterior. Okay, let me go back. So here you have it. Okay, so the serratus anterior arises from the whole of the anterior aspect of the medial border. Remember, I wanted to tell you that it is not all muscles that have good attachment at the anterior and the posterior. So when you are defining the attachment, I can ask you, for example, that serratus anterior takes its origin from the posterior surface. You need to tell me no. I can also ask you, takes, say yes or no, true or false. Is it at the anterior surface or the posterior surface? So these are things you need to mention. That is why I intentionally put the anterior view so that you understand that there are also muscles that could also take attachment on the posterior view. Some can take on both sides, some can just take on only one of the aspects. So we have a tricep. A tricep is a muscle that have actually, three heads, more like three bands that, arise. We have the bicep, we have the tricep. The word tri means the fibers, divisions of the bundlar fibers it has, bi and tri. So that tells you why bi is what you're seeing anterior. The tricep is the muscle that that is just at the posterior part. So this is it. For guys that work out, that do sports and exercise, you want to grow your biceps. So just behind it at the posterior part, you have the tricep. Okay, so we have the long head of that muscle arising from the infraglenoid tubercle. Remember the glenoid, the big circular thing, circular structure, the glenoid tubercle, where you have the glenoid part of the humerus getting attached to. Okay, so that is what we call the glenoid, the infra. So we have the supra. So if you turn the lateral part of the scapula, you're going to appreciate it better. You can see this very well from this, but there is that round big thing where you have the big head, the head of the humerus getting attached to is called the glenoid tubercle. So you have the supraglenoid tubercle and you have the infraglenoid tubercle. So at the infraglenoid tubercle, you have the long head of the tricep arising from it. Then we have at the tip of the coracoid, we have what we call the muscle called the coracobrachialis getting attached to it. So you can see the insertion here, the attachment from the coracoid process down to the middle shaft. So inserting itself to the middle shaft. Okay, so we also have again the tendon of the short head of the biceps. So the tendon of the short head of the also finds its insertion at the center. They have what we call a conjoint tendon. Coracobrachialis, like I've shown you here, actually have a joint, kind of a joint tendon, together with the coracobrachialis, and all arising from the coracoid process, and that is why it is called coracobrachialis. Okay, when we talk about brachium, we're talking about the arm. Anything brachium, we're talking about the arm. So from the coracoid to the arm, that's the meaning of that muscle, coracobrachialis. So the pectoralis minor arises from the coracoid process as well. So you can see the coracoid process. So we've seen some couple of muscles having its origin from the coracoid process. How many have we talked now? We've talked about coracobrachialis. We've talked about, excuse me. So you take note of some of these attachments, so it will help you to keep track of what you are learning and how you are coding them. So coracobrachialis from the coracoid process, and P minor. We talked about P major before, pectoralis major. Now we're talking about pectoralis minor. For pectoralis major, we showed its attachment. Remember? Can you remember its attachment, the lateral end of the clavicle? If you remember, now we're talking about the pectoralis minor, arising from the coracoid process. Now we have the levator scapulae attaching to the superior part of the medial body. Again, this muscle from the word levator means it elevates the scapula. Actually, it helps in elevation. So assuming, let's say this is the muscle is here. Okay, you can see it, the part here. Okay, now assuming this is a string and you tend to draw it, you can see that it can actually elevate, the shoulder. So it helps in elevation. That's why it's called levator scapulae. It elevates the scapula. So it is attached to the superior part of the medial border of the scapula. And then we have the rhomboid minor as well, and rhomboid major that also gets attached, just below it. So we have the levator here, then you have rhomboid minor here, and just after it, you're supposed to have the rhomboid major. Take note of this. At the medial border of the scapula, you're going to have the levator scapula, rhomboid, and then you have the rhomboid major, rhomboid minor, rhomboid major. So this is okay. You can see here, this is actually the muscle. You appreciate the rhomboid minor. The word minor means the size. They're saying that the major is bigger than the minor. So this is the minor, and then this is the major. So you can see where it's lapped. So all of them, look at the attachment to the. So this is the scapula, and look at how it aligns itself. So almost half of the medial part of the scapula. So just at the medial part of the superior border, and from the anterior view aspect, so you're going to have, posterior aspect, you're going to have the levator scapulae, attaching there, and then you have the minor somewhere here, and then finally you have, the rhomboid major down, and then somebody will ask me, okay, what comes down at the tipping point at the inferior view? What inferior angle? What actually should come there? Now we have the latissimus dorsi. Latissimus dorsi is again, you can see not really quite small muscle, a big muscle that finds its attachment and proximal distal attachment of the humerus, the proximal part of the humerus, and its proximal attachment at the inferior angle of the scapula. So you can see that point, this is where it originates from. So you can see it here, the attachment of the latissimus dorsi. So we have the teres major. The teres major arises from the inferior aspect of the lateral border. Now we've moved from the medial border down to the lateral border. So that gives you a sequential view what we're talking about. Remember again, levator scapulae, rhomboid minor, rhomboid major. That's most the sign. Now we're talking about teres major arising from the inferior aspect of the lateral border, no longer the medial. We move to the lateral border, just below the teres minor. Okay, so remember the teres minor, we've talked about the teres minor also being at this point as well. So we're going to have the teres major coming up here at the scapula. Okay, so see the way the two of them are, lashed together. Okay, so you can see the teres major from the word major, the bigger one, and the minor. So you have the major actually very close to the minor, all at the lateral border. Okay, so but what we have at the inferior, remember, we have the latissimus dorsi, we have the minor here, and then we have the major here. Now the small trapezius muscle, the trapezius muscle arises from the superior aspect of the spine. So the superior aspect of the spine, just above the spine, going to have its origin. So you can appreciate the muscle here. You can see the origin as it spreads across, the rib cage as well. So it extends the whole of the rib cage from its superior and inferior fibers, but it takes the origin from the superior aspect of the spine, as you can see here. And we have the posterior fibers of the deltoid arising from the inferior aspect of the spine of the scapula. So the inferior aspect also gives room for the deltoid as well. Remember, we also have the medial part of the clavicle also hosting a part taking origin of deltoid as well. Okay, so take note of that. Now we're also having the deltoid. Some part of the deltoid, the posterior fibers, having a relationship, origin relationship with the inferior aspect of the spine of the scapula. Now, just to give a bit of summary of the scapula, very important, what we call the rotator cuff muscles. We normally say seats. When you say sit down, like seats, that is the mnemonic I use to remember it. Supraspinatus, remember, at the supraspinous fossa, infraspinatus, teres minor, remember, at the inferior angle, and the subscapularis are the anterior border of the subscapularis fossa. Okay, so at the anterior surface, you're going to have that subscapulary covered by subscapularis. So these muscles, if you can have an image of the supraspinatus up there in the superior part, the infraspinatus, at the down part, these ones are actually at the posterior part. And then you have the subscapularis taking the whole of the inner space of the anterior part of the scapula. And then you have the teres minor anchoring it at the tip, the tip in the inferior part of the scapula, giving it a cuff. What you call cuffs, like someone is handcuffed. So it has cuffed, it gives stability, strength and agility to the shoulder, to the scapula. That is why your scapula is not falling off your shoulder. You can imagine the scapula being more like somebody just posted something on your back and you're carrying that. You are wondering why it's not falling off. It's because of the sits muscle. And it gives the anchorage that is being referred to the shoulder for. You can imagine everything that happens with the shoulder. That anchor at the back keeps scapula in position, so we call it rotator cuff, so that you can be able to have somewhat like 360-degree or different forms of movement at the shoulder joint. So that is what is called rotator cuff muscle. Take note of these muscles, but the other ones that also arise from the scapula, just to give a summary of it, the biceps, the heads, the deltoid, latissimus dorsi, P minor, rhomboid major minor, and of course, trapezius, serratus anterior. Of course, any of this muscle can have some kind of muscular weakness, but let's focus on the bone clinical correlate is that we have uh, scapulothoracic dysfunction. Please, I think there's an error. There is no one here. This is basically scapulothoracic dysfunction. So normally when there is uh, malfunction of any of uh, the the nerves supplying any of these muscles, so you have a dysfunction of that particular muscle. So that could lead to what we call scapulothoracic dysfunction or dyskinesis movement. So they are kind of similar. When you lose activity of a particular muscle, it can lead to muscular dysfunction or movement dysfunction. Okay. So we also have what we call the snapping scapular syndrome or what we call the wing scapula. When you see some people, it seems as if you've seen some people, it seems as if their scapula is kind of protruding so outward even when they are standing in anatomical position. Okay. They're not making any movement, but then their scapula is kind of, protruding backwards out of as if it's coming out from their back. That's what we call the snapping scapular syndrome. This is still a result of losing muscular function, muscular agility, muscular weakness, or even loss of function of the nerve that controls that particular. Of course, there could be fractures. It is rare for scapula though, but then a direct posterior trauma at the back can also cause some level of fractures for the scapula. Okay, now let's quickly take a look at the humerus. Very nice bone. Of course, the longest and the strongest in the upper limb. Okay, it is one of the bone in the arm. It's the only bone in the arm, actually, the only bone in the arm, and the longest and the strongest in the upper limb. So it is the first part you're going to see when you talk about the appendicular skeleton. So the first part of the appendage that forms the arm before you talk about um, the ulna and the radius. So humerus it is. So we can appreciate it better when you look at it in the human body, the position it takes. So you can see the connection it makes with the scapula here and the glenoid cavity, remember? So you can appreciate also the coracal process and acromion process hanging around it, okay, anterior and posterior, respectively, okay? And then you can also see the connection it's making at the elbow joint, okay, at the ulna, with the ulna and the radius, of course, the ulna and the trochlear notch. You're going to still see that later. So it has three parts, the proximal end, the middle shaft or the shaft, and then the distal end. These are the three parts, three major parts. So each of them have a lot of features, a lot of clinical correlates that you need to know, important things that we need to mention about them. So quickly take a look at that. And yeah, articulates proximally at the shoulder joint, as I've shown you, and then distally at the elbow joints, as you can see. So you can see the expansion at both ends, the way it expands. Some people describe it as a kind of a triangular as you go towards the distal end, while the proximal end is kind of rounded, and then the distal end is kind of tapered into a triangular form. The middle shaft, the rounding comes up again, and then tapers as a triangular ending at the distal end. So these are the divisions: proximal third, middle third, or the shaft, and then the distal end. And we take the final look of the features that you can map out. We have what we call the humeral head, the head of humerus. That's going to see that more clearly. And they're lined at, this is the part, the part that makes the socket that sucks, puts its head. This is the glenoid. So it gets, okay. Okay, again, we resume from where we start. Okay, let's see. Okay. Okay. go back to, we're now in the humerus, and we're taking a look at the expanded end. Okay, here we have it. Okay, here. So we see the anatomical neck. The anatomical neck is actually where you have the joint capsule. You know, this is the glenoid or the humeral head, where you have the glenoid moving into the glenoid cavity or into the glenoid tubercle of the scapula to form the shoulder joint. And then aligning it is what we call the anatomical neck. Okay, that is the neck of that joint. Then we have what we call the surgical neck. We call this surgical neck because it is very weak part where you have, high instance of fractures. That's why it's called surgical neck. So take note of that. Anatomical neck, surgical neck. So we talked about the um, more lateral, greater tuberosity, and the more medial, lesser tuberosity. So you can see the protrusion I told you earlier, that greater is greater and lesser is lesser. So we've talked about all the muscles, about three, remember, that gets itself attached here. And we've talked about the one that also gets attached from the lesser tuberosity. And of course, the humeral shaft. So this is the proximal end, actually. And we're going to see more of some of these parts we mentioned. This is the head of the humerus for you to appreciate when you get to see the bone. And you can see the head at the both views, the anterior view and the posterior view. Again, just like clavicle and scapula, one can actually take note of which one is the right or the left. Are you talking about the right or the left? So when you position, when you know which is the posterior view, which is the anterior view, that helps you to actually position the bone the way it should be and be able to say this is the right uh, uh, humerus or the left humerus. Okay, this is the lesser tuberosity, as we've seen already, the anterior, and then the superior view. When I mean superior, it means the bed eyes view, as if you're viewed with an aeroplane on top, like from the top. Okay, so we have the subscapularis muscle, which attaches itself to the lesser tuberosity. So you can see the attachment. Now we're looking at the attachment of this lesser tuberosity. So from the whole of the ventral surface of the scapula, so it is helpful for adduction and internal. I think we have seen this before when we talked about that of scapula. Then we have the bicipital groove that separates it comes in between the greater tuberosity and the lesser tuberosity. So, lashing itself out as a groove to divide it into almost two unequal kind of parts. Then we have the long head of bicep inserting itself into that space. So you're going to see the long head of biceps tendon, which originates from, remember, the glenoid of the scapula. Okay, so from the glenoid of the scapula, so you're going to see it, let me use my arrow, my laser pointer. So you can see that here from the glenoid, it's setting itself into that bicipital groove. Okay, and then so passing through the shoulder joint as well to enter into that groove. So that is the relevance of that particular groove. So it is not just in vain, it has a particular purpose. So we have the greater tuberosity as well. And then we have three muscles that are attached to the greater tuberosity: supraspinatus, infraspinatus, and then I think we've seen this as well when we talked about the scapula. So let's not repeat that. So we've talked about the attachment, and we've talked about, now we just need to maybe just take a look at the function. It abducts the arm. Okay, we already know where it arises from, from the supraspinous fossa, and where it attaches to the greater tuberosity, and then the function, and it abducts the arm. Then the other ones are responsible for internal rotation, infraspinatus for internal rotation, and the teres minor. Remember the alignment I told you earlier, how teres levator scapulae starts it rhomboid, remember that attachment. So the same way, you're going to also have the sits muscle. Remember, I call this sits muscle sits. The only thing that is not here is the subscapularis. Okay, we mentioned that before here. Let me show you back again. Okay, so is subscapularis, the only one that is finds itself at the lesser tuberosity. But the other ones find themselves at the greater tuberosity. Take note, the sixth muscle. The three attaches to the greater tuberosity, while subscapularis is the only one that finds itself at the lesser tuberosity. So we move faster now. So teres minor attaches to the posterior part of the greater tuberosity of the humerus. We are now looking at the proximal attachment, the distal attachment. Remember, we said the teres minor, teres major, they are all responsible for pulling, for causing external rotation. Remember, because of the fact that they find its proximal attachment from the scapula. But now we're looking at their distal attachment that is being made on the greater tuberosity. Okay, so teres minor, look at the point here where it is attached at the greater tuberosity. This is the posterior view. That is why you're seeing it like that. So this is glenoid tubercle. And then this is rather the head of the humerus rather. And then this is the greater tuberosity. So on the posterior view. Now you can look at it, appreciate it better here. Look at the muscle, the teres minor, being attached. Remember, see the proximal attachment and the distal attachment. So we are looking at it because we're talking about the humerus right now. So the distal attachment is being made at the greater tuberosity, okay, at the posterior inferior part of the greater tuberosity of the humerus. And it causes, remember I said, if you draw it as a string, you're going to discover that this arm is going to rotate. That bone is going to rotate, to externally, outward. That's what we call external rotation, outward rotation. Now we look at the P major. Remember P major, we had its origin from where? From the middle part. Remember, middle part of the clavicle, the middle third of the clavicle, or the shaft of the clavicle, some fibers, look at it here, okay, and then finding its attachment to the lateral lip of the bicipital groove, the lateral lip of the bicipital groove. So you can see it here at this anterior view of the humerus. So we also have the latissimus dorsi being attached to the floor of the bicipital groove as well. So this groove captures a lot of things. Remember, we've talked about the long tendon of the tricep initially. Now we talked about P major, and we're talking about latissimus dorsi. So this gives you a clear map of how these muscular attachments are made. And also, for some of you that are dissecting, when you're also dissecting, you know what you're expecting to see, because you see a particular muscle, be able to trace it to its origin. You can trace it to its proximal attachment, that's the origin, and the distal attachment, that's the insertion. And you'll be able to understand the relationship with other structures better. Okay, so this is the L dorsi, as you can see here. Okay, and then the teres major attaching itself to the medial lip of the bicipital groove. Okay, this is the teres major. Remember, the major and the minor, two of them are actually together. So, and both are all attached at the humerus as well. So some kind of mnemonics for the attachment, or the muscles that are attached to the bicipital groove. A lady between two majors. What does that mean? Who is the lady between two majors? Who is the lady? Can you think about it? A lady between two majors. We're talking about latissimus dorsi between teres minor, teres minor, major, and teres major. So that's the meaning of a lady between two majors. So a lady, this is the first major, this is the lady, latissimus dorsi, and this is the teres major. So it is in between. A lady between two major means in the mnemonics for muscles attaching to the bicipital groove. Okay, Now we take a look at the deltoid attachment, distal attachment at the lateral aspect of the shaft of the humerus, as you can see with this red pointer here. So you can see it from this view of the body. So you can see the deltoid clearly, and then you can appreciate this attachment and the shaft, the proximal shaft, the aspect of the proximal part of the humerus. Now we also have the coracobrachialis as well, from the coracoid to the shaft as well. So you also have the medial now to the medial aspect of the shaft. You are having, the coracobrachialis muscle being attached, the tendon being attached. So we have the brachialis. Once you have brachialis, we're talking about the arm, but this time it's at the distal part of the humerus, brachialis. We also have the tricep, all the heads, the two heads. We've talked about the long head, remember? I told you that it has three heads, because of once you hear tri, it means three heads. So the long head, we've already talked about the long head. We've talked about how it finds itself at a bicipital groove, remember? And then we're talking about now the tricep lateral head, and then finding itself at this shaft, then the proximal shaft, medially. And then we also have the medial head as well. They are all arising at the medial part of the posterior shaft of the humerus. Now let's look at, remember, I told you three key things: the proximal part of the humerus, the middle part of the humerus. Assuming you are told to write about humerus is unlikely anyway, but assuming someone asks you, it's how you're going to define it. First of all, talk about the things you can see at the proximal level, proximal part of the humerus, the proximal humerus, and the shaft of the body, the shaft of the humerus, humeral shaft, and then you talk about distal humerus. Now we're looking at the distal humerus. You can see a lot of things that looks at structures. So this is the anterior view. Remember, the anterior view of the humerus. We are going to see the greater tubercle by the medial part, and then you're going to see then you're going to see the lesser tubercle on the other part. So now you're going to see the distal humerus. This is the anterior view, and then we're seeing the posterior view. The first two things you're going to make out is the fact that we have what we call the medial epicondyle. The medial epicondyle. So that's the first structure you're going to notice. This is the anterior view and the posterior view of that medial epicondyle. Okay. Of course, we also have the lateral epicondyle. We're going to see that. So the medial epicondyle, but we're going to want to be relating it closely to the structures immediately so that you will not be confused about these things. Medial epicondyle, so you can see appreciate the structure, the anterior view, the posterior view, and the medial view. And then we have attachment of the muscles. So most of remember, we have flexion is one of the major activity that happens at the arm, the forearm. It's able to, have flexion. So at that elbow joint, that is, flexion, what you call flexibility. When you say someone is flexible, that's from the same root word. So flexor origin, we say it is the medial epicondyle gives a common origin. Don't forget this. Gives attachment to the common flexor origin. So some of the muscles that arise, which are flexors, we call them flexors, elbow joint flexor. So these muscles arise from the medial epicondyle: pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor carpi ulnaris. Take note of this: pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, and flexor carpi ulnaris. So we have radialis, we have ulnaris. In fact, from their word, from the pronator, you also know that, have a sense that the pronator also helps with pronation as well. The ones that are flexor are completely strongly flexors. Their focus is on flexion. Okay, flexor carpi radialis, flexor digitorum superficialis means it has a relationship with the digits and some of the attachments. Okay, flexor carpi ulnaris means that it has a distal attachment. Remember, we're talking about humerus already. So it means that it has an attachment on the ulna for it to be called ulnaris. For the radialis, it has attachments on the radialis for it to become radial. For the palmaris longus, it is a very long muscle that extends even up to the palmar surface of the hand. Okay, so this gives you a view. I don't need to cram it. I don't need to study it. In fact, the last time I looked at these muscles has been several years ago when I was a student just like you. So you don't need to cram it. You just need to know the secret behind it. And there you go. Now we look at the trochlea. Another structure you're going to make out is the trochlea. Okay, so you're going to have this trochlea when it makes a contact with the ulna. I'm going to see what we call the trochlear notch when it makes a joint to form the elbow. Very critical. Now we've talked about the medial epicondyl where it gives a common origin for the flexors. Then we have a trochlea, which is at the humerus. So this is another structure. So we look at other views of it, the medial view, the inferior view as well. And then we look at its proximal attachments to form the elbow joint. So you can see the notch here. I don't know if you can see it very clearly. So this is the ulna. So this is actually the bone we're talking about, the humerus. So you can see how it attaches itself, to form the trochlear notch of the ulna to make the elbow joint. Okay, so we now have another fossa called above that trochlea. We have what we call the coronoid fossa. The coronoid fossa. So we have the ulna also has the coronoid fat. When there is a movement, the flexion, when the arm is flexed, you are going to see that the coronoid process gets to, make a touch at the coronoid fossa at this point. So it makes a touch at the coronoid fossa. So this is fossa. Remember, this one gets to attach the trochlear notch, and as the elbow moves, it glides over this, and then the coronoid process of the ulna makes it touch the coronoid. So this is the fossa, the impression you can see here. And then we also have at the posterior view, just like we have at the anterior view, posteriorly, we have what we call the olecranon fossa. Where the olecranon process, again, the olecranon process of the ulna articulating with the olecranon fossa as movement is made. So when extension happens, it locks, where you say the elbow lock, it locks it up at that place, at the olecranon fossa. So now we have another bony projection very close to the anterior view, which is called the capitulum. So you can appreciate the capitulum of the humerus. You see the relationship. It makes some kind of relationship with the radius as well. So while the trochlea makes a relationship with the ulna, the capitulum makes a relationship with the radius, all at the elbow joint. So these are the formation of what forms the elbow joint. So look at that connection I was talking about. So you can see, remember, then ulna is medial while radius is lateral. So that helps to know the positioning of these bones in the body. So we also have the radial fossa. The radial fossa articulates with the radial fossa in flexion of the elbow. So when there is flexion, so you also see, just like we have the trochlear notch. So we have the coronoid fossa that makes gets that receives the coronoid process of the ulna. We also have the radial fossa that receives the radial head, rather that receive the radial fossa, the radial radius, when flexion is being done. So let's look at that patch at this place. Okay, so the radial head articulates with the radial fossa in the flexion of the elbow at this point. Okay, so we look at the other part of this distal part of the humerus. We have what we call the supracondylar ridge. Supracondylar ridge. So once you hear condylar ridge, we have what we call the condyles. Condyles are just at this point, we have the medial and the lateral part, but we're making reference to the one. So we have the medial and the lateral part, and then we have at this end is what we call the supra, means above, just a little above here. We say it is supracondylar. So there is a ridge, the way you say ridge, climbing a surface. So this is more like a ridge here. There is also another ridge here. So it gives rise to brachioradialis. So that is where you have brachioradialis muscle taking its origin. So you can see it here in a full, you can see the arm and forearm, so you can see it here. Okay, you can also see its attachment at the tipping distal end of the ulna. So we have also the lateral supracondylar ridge giving rise to extensor carpi radialis longus. These are, remember we talked about flexors, now we're talking about extension. Remember, we talked about the medial epicondyle giving rise to most of the flexors. Okay, palmaris longus and other flexors. Now we're talking about lateral supracondylar ridge giving rise to some of the extensors. Brachioradialis is one of them. Extensor carpi radialis longus is another one. It's long. Once you say carpi radialis longus, so it means that there is a relationship with the carpal bones. That's the meaning of carpi. Longus is talking about the length. You can see the length. And then radialis means where it is finally actually inserting. Okay? Now, extensor means the function. It's relevant for extension. So these are things that help you there are very, very few exceptions to this, but from the name, from the nomenclature, you'll be able to at least relate with the function of some of the muscles you will see. So extensor carpi radialis brevis, extensor digitorum, extensor carpi ulnaris, extensor digiti minimi, all arise, gives attachment to the common extensor origin. So medial epicondyle, common flexor origin, lateral epicondyle, common what? Flexor origin. Take note of that. Medial epicondyle, common flexor origin, lateral epicondyle, common extensor origin. Let this stick to your head. Extensor carpi radialis, the same way we have flexor carpi radialis longus, we have flexor digitorum, we have palmaris longus. Those are the flexors. Now we're talking about the extensors. Okay, extensor carpi radialis, extensor digitorum, extensor carpi ulnaris, extensor digiti minimi. Very important. All come from, this is the posterior view, okay? So you're going to see the attachment from this common extensor origin. We also have the very small and conus muscle that also takes its origin just below the common extensor muscle. So you're going to see it here, just at that same part of the lateral epicondyle. So lateral epicondyle, you're going to see. So look at it. That's very small muscle that locks itself. So when you're dissecting, you're going to take note of this muscle, and you'll appreciate it better. Let's talk a little bit about some of the relationships that is very close to the humerus. The axillary nerve, especially now, when you're studying your brachial plexus, you're going to understand that the axillary nerve are going to give some branches that we call the circumflex branches, right? The circumflex means that it's like the way you say circumference. Okay, now I'm saying circumflex. So you're going to see it's around, as if it's rounding the neck. Now, the surgical neck. Okay, at that surgical neck is where we also have the axillary. So most times, the word surgical neck of the humerus is also related to the relationship of the axillary nerve to the humerus. The relationship the axillary nerve makes to the humerus is why it is called the surgical neck, because it is more prone to damage that will lead to a lot of clinical implications. Of course, loss of function of several places that are being supplied by axillary nerve and its branches as well. So the axillary nerve touches the posterolateral aspect of the surgical neck of the humerus, and we also have other nerves that are related to it. The radial nerve as well has a relationship with the humerus at the lower part of the humeral shaft here. So you can see it's more like at the end of this, that is more like a spiral groove. on the lateral aspect. So take note of that word, spiral groove. These are some of the things that you're going to be seeing if I'm asking you any questions to choose or to select. You're able to test your knowledge. So you need to know the surgical nerve relations by showing nerve. You need to know the placement of radial nerve. You need to also know that of the ulnar nerve as well. So at the posterior aspect of the medial epicondyle of the humerus, you're going to see the ulnar nerve making a touch to it. So these are the three nerves that are closely related to the humerus: axillary nerve, especially the circumference branch of it, and then the ulnar nerve, and of course the radial nerve at the spiral group of the lateral aspect. And why the ulnar nerve is at the posterior aspect of the medial epicondyle. Okay, so this is just to show it one more time. The medial epicondyle, the posterior aspect of medial epicondyle, the lower, that's for the ulnar nerve, the radial part and the spiral group of the medial shaft, and the axillary nerve at the surgical neck. Okay, all at the posterior part. Okay. Now I want to look at some of the correlates of humerus. Normally, we have what we call the surgical neck fracture, which is a major site. There are other fractures that could arise, but this is the weakest point actually of the humerus. So this is important to note. Also, that will also be osteoporosis, that the weakening and the brittling of the bone as well that will occur. There is also possibility of avulsion. Okay, so when you are seeing the glenoid part of the humerus is being avulsed from the joint, from the shoulder joint, as if it's getting detached. Sometimes when there are some kind of diseases or some joint issues or some capsular issues, osteoporosis, avulsion can occur that will make the head, or a direct impact to the shoulder, the head can be avulsed. The head of the humerus can be avulsed from the joint. So we also have other types of fractures that is being called the ARM, for axilla, when the fracture is at the axillary part. The radian is when it's at the middle shaft, and then the median when it has the distal end of the humerus. Okay, so I'm going to give you, that's the end of the lecture for today. I'm going to give you a link where you can ask questions. I'll also drop my email with your class reps. You can ask questions, or whenever we see in class, you can also ask your questions, and any clarification you need, or you'll be able to get that clarified. Any questions at all is welcomed. So thank you very much.